So this is external oblique aponeurosis. This is the muscle which becomes aponeurotic. So the lower free border of external oblique aponeurosis extending from anterior superior iliac spine to pubic tubercle infolds and become double folded to form the inguinal ligament. So this is the inguinal ligament, the lower double folded free border of external oblique aponeurosis. This goes and attaches to the pubic tubercle. So above the pubic symphysis, the external oblique aponeurosis has got a triangular slit with the base directed below towards the symphysis pubis, apex directed upwards and laterally towards the anterior superior iliac spine. It has got a medial lateral limb and a medial limb, or you can call it as medial crura and lateral crura connected by intercrural fibers. So this is superficial inguinal ring, a triangular aperture 1 cm above and lateral to the pubic tubercle in the external oblique aponeurosis. This is the spermatic cord. After invaginating through the external oblique aponeurosis through the superficial ring, it acquires its outermost covering called external spermatic fascia. Posterolateral to the spermatic cord, this structure is the ilio-inguinal nerve. This is another content of the inguinal canal, which also accompanies the spermatic cord to supply the skin of the root of the penis and the scrotum. So, the spermatic cord, ilio-inguinal nerve, superficial inguinal ring. So, we have cut the external oblique muscle from its attachment in the ribs and we are displacing it downwards. What we are seeing here is internal oblique muscle. Deep to that will be the transversus abdominis muscle. So both these internal oblique and transversus arises from the inguinal ligament. This is the upper grooved surface of the inguinal ligament. This is a double folded external oblique aponeurosis. What you are seeing here is the grooved upper surface of the inguinal ligament. So you can see from the inguinal ligament the internal oblique muscle as well as transversus abdominis arises. These two inguinal fibers of internal oblique and transversus, instead of crossing across the rectus abdominis to reach the hernia alba after contributing to rectus sheath, will bend downwards and medially, passing posterior to the spermatic cord to gain its insertion into the pubic tubercle. So this part of the internal oblique and transversus arching above the inguinal canal to gain insertion into the pubic tubercle is called as conjoint fibers of internal oblique and transversus or falx inguinalis. So initially it will be anterolateral to the spermatic cord, then it runs superior, and at close to its insertion it is posteromedial to the spermatic cord. So this is related on all directions to the spermatic cord. So this is a spermatic cord, this is the inguinal canal. Deep ring I have not traced. Unless I cut these inguinal fibers of internal oblique, I won't be able to trace the deep inguinal ring, which I will show you in the next side. This is the spermatic cord. This is the grooved upper surface of inguinal ligament. This is the arched conjoint fibers of internal oblique and transversus abdominis. External oblique aponeurosis, which I have dissected here to expose the upper grooved surface of inguinal ligament. Unlike that side, here I have cut open the superficial inguinal ring also. So you can see the spermatic cord with the ilio-inguinal nerve, the contents of the inguinal canal. This is the conjoint fibers of internal oblique and transversus fibers arising from the inguinal ligament. So this is the arched conjoint tendon gaining insertion into the pubic tubercle, forming first lateral anterior, then superior to the spermatic cord, and then in the posteromedial side of the inguinal canal it is inserted in the pubic tubercle. Now I have cut the conjoint fibers of internal oblique and transversus abdominis to show you the deep inguinal ring. What you are seeing beneath is a fascia transversalis. So you can see the spermatic cord invaginating through the fascia transversalis acquiring a covering. That's the first covering along with the processus vaginalis, internal spermatic fascia. Now when I dissect further, you can see inferior epigastric artery, lateral border of the rectus abdominis and the inguinal ligament. This triangular space in the posterior wall of inguinal canal is called as Hasselbalch's triangle. So you can see this inferior epigastric artery's lateral side contains a deep inguinal ring. So if at all hernia occurs through deep inguinal ring, the neck of the sac will be present lateral to inferior epigastric artery, and that type of hernia is called as indirect inguinal hernia. On the other hand, if it occurs directly through the posterior wall of the inguinal canal, due to weakness of the abdominal muscle tone, it will be lying medial to the inferior epigastric artery. Such a hernia occurring through Hasselbalch's triangle on the medial side of the inferior epigastric artery is called as direct inguinal hernia. So this is the spermatic cord. This is the deep inguinal ring. You can see few fibers of internal oblique arching above the deep ring. These are called as interfoveolar fibers. This will try to close the deep inguinal ring whenever abdomen pressure increases. Then after invaginating through the deep inguinal ring, the spermatic cord invaginates through the internal oblique and transversus. As it is invaginating through internal oblique, it acquires the cremasteric muscle and facial covering. That cremasteric muscle is supplied by genital branch of genitofemoral nerve. Then finally, when it is invaginating through the superficial inguinal ring, it acquires the external spermatic fascia covering. So this is the ilioinguinal nerve accompanying the spermatic cord in the inguinal canal. So this is the inguinal canal stretching between deep inguinal ring to superficial inguinal ring. Floor is formed by the inguinal ligament. Medial most portion is contributed by lacunar ligament. Roof is formed by conjoined fibers of internal oblique and transversus abdominis. Anterior wall is formed by the skin and two layers of superficial fascia, external oblique aponeurosis. Lateral portion is contributed by conjoined inguinal fibers of internal oblique aponeurosis. The posterior wall is formed throughout by fascia transversalis. A small medial portion is contributed by the insertion of conjoined tendon into the posterior pubic tubercle and reflected part of the inguinal ligament. So these are the boundaries of the inguinal canal: spermatic cord, ilioinguinal nerve, conjoined tendon, fascia transversalis, deep inguinal ring invaginated by spermatic cord, inferior epigastric artery, lateral border of rectus abdominis, inguinal ligament forming Hasselbalch's triangle.